Well, I'll just like before, I'll invite each one of you to give a brief introduction and background of yourself. So we'll start with Dr. Babu.
Hi, thanks for the invitation to join you tonight. So I'm a neurosurgeon. I practice in the Treasure Coast region of Florida. So I trained at Mayo in Minnesota. I grew up in Minnesota and did a trauma fellowship down at Ryder Trauma Center. I've done a critical care fellowship, neurocritical care, and then I've also done a functional enfolded fellowship. But my practice is a generalist practice. My first position was actually out in Boston in academia at Mass General. And I'm actually more in a community hospital environment, which I really enjoy. Our hospital system was just acquired by the Cleveland Clinic Florida system. So it's been a bit of a transition. But like I said, my practice is a generalist practice with cranial and spine. And I like the diversity. I love the diversity of neurosurgery, and I look forward to answering your questions.
Okay, great. Thank you. Dr. Boop.
Well, my name is Rick Boop. I'm a pediatric neurosurgeon in Memphis, Tennessee. I've been here for 22 years and was at the University of Arkansas and Arkansas Children's Hospital for a decade before that. Our practice here is what we call a private-demic model, whereas when I was at Arkansas, I was faculty in a traditional university teaching program. Here, it's a large multi-specialty group that is a private practice group that has an affiliation with the university and trains residents. So I was chairman for the past decade and stepped down as chairman in July of this year, and have been involved with a number of different things. Ed and Maya and I have all been working together for a long time in our Council of State Neurosurgical Societies, which is more of a grassroots effort. But I've been involved with teaching medical students and residents for over 30 years. And I can tell you it's slowly evolving, but probably the important things to know about neurosurgery are that we make up about 1% of the healthcare pyramid. So we're a treasured resource. My best advice to people who think they want to be a neurosurgeon is to spend some time with us ahead of time so that you make sure that that's the right choice for you, because it's not a job. It's truly a lifestyle that you choose when you go into any of the surgical disciplines, but particularly neurosurgery. Someone asked earlier about diversity, and Maya can talk about women in neurosurgery, but I think all of the surgical subspecialties are very interested in DEI at the present time and are actively trying to increase numbers of diverse applicants. Historically, about 7% of neurosurgeons are female. If you look, for example, at neurosurgeons, about a third of us are female nowadays. And it's a specialty that has enough variability to it that there's lots of opportunities for anyone in the field, as long as you're willing to work hard and show interest. Ed?
Oh, my turn? Okay, I will go next. My name is Ed Bates. I'm a neurosurgeon at the University of Rochester. My journey here started, I actually grew up in Wilmington, Delaware. That's where I was born. My father was a neurologist, and that's how I guess I got my first exposure into neuromedicine. I went to college at Duke, and then did MD, PhD training in New York City. Got my MD at Cornell and my PhD at Rockefeller. My PhD was in studying how birds learn to sing, which is maybe a little esoteric for tonight, but if anybody's curious, feel free to message me. I then matched in neurosurgery training at the University of California, San Francisco, completed residency and went into fellowship at Brigham and Women's Hospital in Boston for a year, where I did fellowship training in cerebrovascular and skull-based surgery. Then I got a job here at the University of Rochester, and I've been here for the last 17 years. My practice is fairly specialized in that I focus mostly on pituitary and endoscopic and open skull-based surgery. But yeah, and one of the questions came up about specializing in orthopedic oncology, and I think the same answer applies here. You can specialize to the degree that your community is able to allow you to specialize. In smaller communities, there may not be a volume for you to do specifically and only what that one thing is that you want to do. And so that means that you may, by definition, have to also continue, practicing in the general aspects of your field. But in typically larger urban areas or healthcare systems where there's a funneling mechanism that brings the subspecialty cases to the subspecialty providers, that's how you can really focus in. I personally enjoy having my focus, but then still being involved in general neurosurgery, typically cases that come in when I'm on call, because it means that I'm taking call, I'm interacting with the residents, getting to still think about things that are interesting, just not necessarily my specific area of expertise. And I think it's important in many ways for even specialists to maintain an interest and ability to deal with many of the things that are in their specialty for the purposes of educating residents and educating medical students. And so that's an important aspect of my career. And then I guess at this point, let me go ahead and hand it off to Chris Carroll.
I'm Chris Carroll. I'm a active duty Navy neurosurgeon in Portsmouth and Virginia Beach, Virginia. Did college at the University of Chicago and worked in a neurosurgery lab for work study, just doing solutions and parsing down rat populations, things like that. That's kind of how I got exposed to it. And then friends having a couple of injuries, but really kind of fell in love with the kind of intricate dissections we did in that lab. And then went to med school fairly undecided, ended up doing med school in Milwaukee, Medical College of Wisconsin. And then pretty early on, got involved in TBI research and in the department at MCW. Ended up doing residency at the University of Cincinnati Mayfield Clinic, which was a private practice like Dr. Boop's practice at Memphis when I was there. Really developed an interest in skull base and cerebrovascular with our chairman, Dr. Zuccarello, our former chairman, Dr. Tu, and ended up doing an endovascular fellowship at the University of Florida. But because I'm in the military, I have not been able to use that fellowship once in my time on the outside. The majority of my time in practice is doing, non-operative care. I do a lot of sports medicine because I'm the consultant for Navy Special Warfare and Marine Special Operations Command. Research, I've done a lot of neurotrauma and animal models. And then in practice, we do a lot of spine surgery, a lot of degenerative spine, some trauma. But really a lot of it's counseling people and doing non-operative things for the command and for people who are kind of at the tip of the spear. I am, because we're a joint program with orthopedics, we're owned a department. I'm the department head with 7 surgeons. But the orthopedic training program, there's only 3 orthopedic spine surgeons in the Navy. So they merged into our department to ensure continuity of that training for the orthopedic residents. So I'm the director of the spine education program. That's kind of how Milwaukee was. Cincinnati was very collaborative. Milwaukee, because there was only one orthopedic spine surgeon, was very much a merged training environment. And so we've tried to foster that here as a model for the rest of the Navy to ensure that the orthopedic residency programs, because we don't have a neurosurgery program, have a very robust exposure to a breadth of spine surgery as well.
Great. Thanks. Always the $1 million question. Tell us about your work-life integration. We'll start with Maya.
Well, I think it's, to be honest, it's kind of what you make of it in terms of, you have to choose your practice if that's a focus of yours, if you have personal commitments, obligations that you value, and it may not be where you think you want to be, if your dream or aspiration is to be at a, big name academic center, you may have to sacrifice something if you have, personal responsibilities or commitments that take precedence. And so I think, like, as with anything, if your focus is family or any sort of personal obligations, I think you can make it work. But you have to figure out a practice model that fits you, and it's going to take some time. I mean, I think there's different hybrid models as well. Some folks, will be contracted, to do almost a part-time, role depending upon a hospital's need. Not necessarily something I think folks coming out of training are interested in, but I know some senior folks who have done that because they don't want to leave the practice of surgery altogether, but they do want a little bit more time. So I'm not trying to hedge, but I think as with anything, it's doable, but you just have to know what's important to you and kind of clarify your order of priority in terms of your commitments.
Yeah, I always think everyone asks how many days, how many hours. I think it's so variable. It's really hard to quantitate, and having sit through a number of these subspecialties over the years, I mean, it's hard to say, well, we work X number of days or X number of hours, but so.
I think as a med student, a lot of people are kind of daunted by this idea of working 90 hours or working 100 hours or working 70 hours. I think Dr. Boop really hit it on the head. There's so many different ways, like Dr. Babu was talking about, to really personalize it once you're out of residency. Residency is 7 years. The rest of your life is your career in neurosurgery. And you can really shape that towards your personal interests, right? Like, I can't do cerebrovascular, but I was an athlete. My dad was a warfare officer. I want to be with combatant command. So I kind of weaseled my way into working with SEALs and doing kind of spooky stuff. And just like I have friends who they have private practice spine practices where they start work at 6 a.m. They're usually done by 3:30 in the afternoon. They operate 2 days a week. They see clinic 2 days a week with a PA and an MP. And they have a lot of free time with their families in the afternoons, evenings, and weekends. Because they're at level 3 trauma center, or they don't take trauma call very often. And I have friends who we had 1/3 of our residency program was female. My co-chief had 2 kids during residency. One of the girls 2 years behind me had 3 kids during residency. Like there's an opportunity for everyone to kind of find something that suits them. And as Maya was saying, it's life is sacrifice. So while I would love to go, and not have missed my brother's wedding, I had to do things with the military. While I would have loved to, maybe go to the Blackhawks playoff game in 2013, I was an intern. I wasn't on the cards, right? I had to watch it on TV as a rerun. So you find the things that are important to you and you emphasize those, like, my kid's first day at school and doing things with friends and family, and you kind of the other things that are less important, less critical to your quality of life tend to drop to the side. Because as Dr. Boop said, it really is a profession that you're kind of all in, even when you're not working. It's something you have to be ready to go. Because even though I'm not on call, one of my junior partners who are 3 months out of residency may call me tonight and say, hey, I have a posterior fossa hemorrhage. I need your help because we're at a military hospital, and sometimes you're kind of making sure everything gets put together right, and you need somebody who's been there a while. So the things that are important will kind of rise to the top, and you'll weed out those other things.
And I think a couple of thoughts through my mind. One is, if you choose a specialty because you think it will give you more flexibility in other elements of your life, but it's not something you really like, that's going to suck. And will make the other parts of your life not as much fun either. I also think that one of the essential skills that you learn in any specialty really within the house of medicine is how to figure out what's important when it's important. And the analogy I use is that on any given day, I'm juggling 6 balls, and each day I got to figure out which one of those balls is the glass one that I can't drop. The other ones I worry about too, but they're more resilient, and I can, really focus on the glass ball because that's the thing that's most important that particular day. And on any given day, that might be family issues. On another day, it might be there's a grant deadline. On another day, it might be I've got a meeting that I have to be at for the AMA, and that's something that I have to do because it's important for the field of neurosurgery. And on any given day, which ball is the glass ball is going to change, and you just have to get really good at juggling all of them. And I think that's an analogy that really fits kind of certainly within all specialties of surgery and probably more broadly within medicine.
Yeah, I'd like to address the question that's come up several times about spine ortho versus neuro, and just make the point that either discipline can train a spine surgeon. In fact, it's interesting nowadays, a number of neurosurgeons interested in spine will do an orthopedic spine fellowship just to get a different picture of what they're going to be doing the rest of their lives. But about 2/3 of neurosurgeons do spine for a living. And then nowadays there are people who do very complicated spine work, deformity work, trauma center type work that can be very challenging. But the people that do really complicated stuff typically will be part of an orthoneuro team doing really complicated spine. And I'll mention that neurosurgery often is a team sport, no matter what aspect of neurosurgery you end up doing. Most neurosurgeons nowadays don't do everything. They limit their practice to what interests them the most, whether it's peripheral nerve surgery, intracranial surgery, head, neck, and skull base surgery. And most of those disciplines will require you to work with someone else. If I do craniofacial surgery in children, I work with the plastic surgeons, I work with the oral surgeons. If I do skull base surgery, head and neck tumors and that sort of thing, I work with the ENT head and neck surgeons and the plastic surgeons. Oftentimes, if our peripheral nerve people are doing complex hand work, they'll do it with an orthopedic hand surgeon or a plastic hand surgeon. If you go into functional neurosurgery, you may even be part of a team working with non-surgeons, such as neurologists who are expert in Parkinson's disease or experts in epilepsy. So it's good to be a team player if you're going to go into our discipline, for sure.
I'll sort of ask another question. I know, like in the extreme for private practice, are they still subspecialized like this, or are they doing more general neurosurgery and then sending out more difficult cases?
I think for most private practice, it's fairly general. There are some private practices that, because of their size and scope, have actually offered, I would say, very tertiary services, some that offer skull base, et cetera. But in general, I would say the majority of community-based practice is spine for neurosurgeons who are in independent practice, or, not academic, I should say.
I think it depends a little bit too on the community. So for instance, we have a couple of residents that graduated together. They were a married couple, and they went into practice in Fort Smith, Arkansas. And in that community, there's a very broad range of pathology, whether it's transnodal pituitary surgery or open skull base or aneurysms or spine. And given the nature of that community, where patients do not want to travel or do not have the resources to travel, they take on everything. And there have been times when Ken was doing a pituitary tumor and had to go back in because there was a lot of tumor left behind, and he wanted help. I mean, he called me up and I, Kate, his wife, FaceTimed so that I could see the view on the monitor for the microscope and kind of walk him through it. But, they're both taking on everything, because that's what their community needs. And fortunately, not just our program, but I think most neurosurgery training programs do a really good job in teaching people how to do pretty much everything they need to do. There are some areas, cerebrovascular is one, really complex instrumented spine is another, peripheral nerve is another, where fellowship training definitely confers quantitative and qualitative value. But if you're at a good training program that's still doing all those things, even as a resident, you will probably pick up enough that if you are on, a desert island or in a community where someone really needs to be doing everything, you can do it.
So this will transition into the next question. So what happens, like, if you see something you've never seen before? How do you think?
Never happens.
Never happened. You've seen it all.
Well, I think we're fortunate in that as a profession, we're relatively small. as Dr. Boop alluded to, 1% of doctors, 3,000-ish neurosurgeons in the country at the time. And where we are just with the Navy and we're kind of a very advanced community hospital in that we have the individual ability to do most things a trauma center could do, but we have the institutional capacity to do a very small subset of those things. So like when we have our tumor patients, we don't have the adjuvant care. We don't have the capability to do radiosurgery. We don't have DBS. We don't have, could I clip an aneurysm in an emergency? Sure. If we could find the clips, I wouldn't have ICG afterwards. I don't have angio. I have a general ICU. I don't have EEG. Like we send them across the street, and those neurosurgeons are more than happy to work with us on not just when I call them at night, say, hey, I've got a pontine hemorrhage that I think is a cavernoma, but just talking about like, hey, if these kind of things come up, how do you want us to manage this? How do you want us to get that? We do a lot with Duke and UVA and VCU, which are big academic centers in the region for more complex oncologic and cerebrovascular care. And then for pediatrics, we have really strong collaboration with the pediatric neurosurgeons at the local community kind of tertiary pediatric center. So, it's really this collaboration. If I don't know somebody, one of the people I train with, one of the people I work with will know somebody at UVA or at Miami, or we have a person, because it's the military, moving to Texas. I can call a friend or call somebody I know, and they'll know somebody at UT San Antonio, or they'll know somebody at UT Southwestern, just because it is a very small community of surgeons. And I think I've never run into another fellow surgeon who's not willing to even just talk me through something on the phone. I know I reach out to Dr. Zager at Penn on peripheral nerve tumors. And then, like people are saying, I don't have a subspecialty fellowship in peripheral nerve surgery, but I have a plastic surgeon and orthopedic oncologist who love to do them. We kind of do them together. So when I had an ulnar schwannoma, I had brought a plastic surgeon in to do the exposure with me, make sure it wasn't something where we'd have to do grafting. And it's really a fantastic way to build that skill set amongst the different surgeons in a lower volume practice and preserve those cases at our hospital. So working on that team, I think, is essential, especially once you're staff, and recognizing where those shortcomings are. If you haven't seen it, there probably is somebody who has, and not having that that hubris to think, you know better than someone else. Phoning a friend is always, the first step for me if it's something I'm not used to or don't recognize.
I'm also reminded in hearing that question, Werner von Braun, who pioneered the Saturn V rockets that took us to the moon, also built the V2 rocket, so not a completely unblemished moral record. But he was famous for a statement that he said, where he said, "Research is what I'm doing when I don't know what I'm doing," which sounds somewhat flippant, but I actually think that it's an important indicator of why research is important, not just for neurosurgery, but for orthopedic surgery and really throughout all surgical specialties. If you're doing something and you're not exactly sure why you're doing it, if it's something that you just learned because you saw someone else do it, or you're not even sure it's the right thing to do, then that means you should be asking questions about, what was the outcome? What happens if I do this again? What happens if I do it differently? And I think that being comfortable at that interface where you've gone past the limits of your knowledge and are staring out into the unknown is a very common thing in surgical practice, and it's why research is an important part of surgical education in all specialties. I mean, I think neurosurgery, we have a year of dedicated research time. I think a lot of other surgical specialties do that as well, or make that opportunity available to their residents. And I think that's why, because you will very frequently be in a position where you've never seen this before, you don't know exactly what it is you're going to do.
Every day.
Yeah.
So similar to the last group. So when did you know you wanted to subspecialize? Is it advisable to go into a neurosurgery residency knowing what you want to do, like spine or pediatrics? When's a good time to change, or can you change like during mid-career?
I mean, I'll tell my personal journey. When I started residency, I thought, because my PhD was in song learning in birds, which I mentioned, it involved a lot of neurophysiology recordings, and I thought I was going to do, maybe, tumor surgery with awake corticography. Actually, my thesis, the very first page of my thesis, I mentioned a neurosurgeon, George Ogeman, who is very famous for developing the technique for awake speech mapping. And about I want to say halfway through my second year, I'd seen enough of that to know, nope, that was not what I was going to do. And then I was, I think towards the end of my second year into my third year, and I had the opportunity to work with Mike Lawton, who was a junior faculty member at that time. It was my first time really seeing open aneurysm surgery. And it's one of those, what I call a burning bush moment. It's like the clouds parted, little beams of light shone down, little angelic voices started singing. And I was like, oh, that's what I'm going to do. Sometimes it happens that early, sometimes it happens later. And I think it happens when it happens. For each individual. I think the earlier you can know, sometimes that's better because it helps you prepare for whatever the next step is going to be, whether that's fellowship training or really focusing on that training during your residency. But assuming you're at a good program where you've got good mentors who can help shepherd you through that process and land successfully at whatever the subspecialty next step is, I think you're going to be fine. And there are lots of neurosurgeons who have gone and done fellowship training after they've already been out in practice for a while.
Maya, what would you say to that?
Yeah, I think for me, I feel like it's always good to really approach the start of training with an open mind, because just like finding a specialty, I mean, I think going through rotations is so helpful because you get to see everything in medicine, from OB, family medicine, pediatrics, et cetera, and just kind of find your what excites you. I think you shouldn't feel pressured to know all the answers before you start. And I think there's always room to change. I mean, I completely agree that your happiness should be paramount. And if it's not a good fit, it's not a good fit, and it's not worth it to try to make it a good fit. So I think finding a fellowship is a evolving process. And I think too, you might find a direction and feel kind of too pigeonholed, and you might change direction later on. So for me, I felt kind of more committed to one thing, and I really wanted to be a generalist, and that's what made me happier. And so I kind of changed where I was practicing. And so I think that's a very much a realistic possibility. And I don't want anyone to feel burdened by making all those important decisions early.
Yeah, I would add, Stephen, that our field is changing so quickly that people don't necessarily end up their career doing the focus that they started out with. I'll tell you, my father was a Navy neurosurgeon, Chris. When I was 3, we were at Norfolk, but he came out of the Navy at the peak of Vietnam with a huge experience with shrapnel injuries, peripheral nerve injuries, and his first 10 years in practice was the expert in peripheral nerve at our university. Then he got interested in microvascular work, and he did trigeminal nerve decompressions and a lot of work under the microscope for about a decade. And then in the last 10 years of his career, he focused on chronic pain and treatment of pain disorders. So people change throughout their career. One of the nice things about neurosurgery is you have a skill set that allows you to do that.
Yeah, I think during residency, I kind of shifted towards, I came in knowing I was in the military. I was really interested in neurotrauma. I'd had 2 friends shot and killed. I'd had 1 friend on a soccer field, put into a coma with an epidural. And so I'd always been interested in trauma. I'd always been very interested from day one in medical school, even in college, in anatomy, and loved dissecting. And that was really my favorite class my first 2 years. And we had a PhD anatomist, Jeffrey Keller, who was just fantastic and a great mentor in his own right, not a surgeon, but just that passion to understand the roadmap of neurosurgery, which is anatomy, both cranial and spine, was always with me. And I think I enjoyed the anatomy of the skull base and vascular cases a lot more. I really like peripheral nerve anatomy and the micro dissection element that we didn't see as much, but we saw some of it. And so I think I'm going to fall into that boat. I've done a fellowship. I won't be able to do it for 6 years. And I'm probably going to have to redo a fellowship if I want to get back into cerebrovascular when I come out. It's very easy, later on in your career to find partners or find opportunities to do that. And I think, as Maya said, you won't really know until you're not just doing the cases, but dealing with the patient populations too, which is a lot of the outpatient clinic and the family discussions you have at 1 a.m. with people. You may think you love aneurysm surgery until you see some of the people in outpatient clinic. You may think you love neurotrauma until your, fourth, discussion about DNRs and the most horrific thing that family's had in their lifetime in one night. And that weighs on some people and they end up doing other things. And so some of that you can't really have a sense of until not just residency, but later in residency and when you're, a junior faculty.
Well, great. So we're near the end. I'll ask one more question that seems to be popular with all subspecialties is, where's your field going? What are some of the new innovations going on, minimally invasive techniques such as endovascular stenting? So what are some of the hot new techniques going on in neurosurgery?
Well, I can start out. I think depending on the subspecialty, we're very tech heavy, I would say, across the board, and spine, a lot of innovation with robots, doing not just, minimally invasive approaches, but, really with instrumentation, just giving us access. I mean, I think there's a lot of exciting things happening. Certainly, the entire field of functional and stimulation for, pain procedures, spinal cord stim is based on technology and advances in technology. Trauma, there's we use, various things that we implant, but, I think there's a lot of interest in stimulation and ways that we can harness, electrical signals to, modulate the neural networks and neural systems. So, I mean, I just feel like in every subspecialty of neurosurgery, there's just so much innovation and application of technology.
I would echo that. People used to say people who go into neurosurgery go there because they like to play with expensive toys. And I think that's pretty much true. The major advances in neurosurgery in my lifetime have been through neuroimaging advances and what that's allowed us to do. And for example, if any of you have seen the new 7 Tesla MRI images, you can see the dentate gyrus in the hippocampus. You can see defects in the walls of blood vessels. With functional imaging, we're able to see where function comes from. And with new stimulators, new ability to lesion, for example, non-invasively with focused ultrasound and things like that, our specialty is evolving at a tremendous rate to the point that our textbooks are out of date by the time they're published. So, and of course, you can talk about the advances in endovascular. I mean, that's so fast, I can't even keep up with it.
Well, and I think, part of what a lot of our research goes to is making some of these surgical things that we do that are, admittedly very morbid, even just, people consider bread and butter spine procedures like fusions. You have a really high, failure to respond rate. You have high morbidity relative to other specialties. We're not taking off moles. We're not replacing knees, which are complex in their own ways. But, there's lots of things we're really geared towards trying to make our own jobs obsolete, right? If we could find a way to cure GBMs without ever cutting a head open, that would be glorious, right? That'd be like, not only would somebody win a Nobel Prize, but that'd be an amazing impact on humanity and the care for these people. So when you have people going from these like transfacial approaches for skull-based tumors to working with their ENT colleagues, putting an endoscope up with their kind of skill set, taking their knowledge of that kind of relief anatomy of the skull base and using that to get to these tumors more directly, it's really changed how we do these things. I mean, I'm at a glorified, community hospital, and we still do, because I have a really good rhinologist with me who trained at UNC with a great program. We do a lot of anterior skull base. We do expanded transphonoidals, we've done grafties, we do craniopharyngiomas, and that's just because of that technology allowing it to be more accessible to us. Endovascular is the same way, right? You don't have to be the smoothest hands and have that masterful dissection of an arachnoid plane to go in and put up a pipeline stent across a pecan, right? It's much easier technically to do. Now you can still hurt people grievously with those techniques. And I think there's always a discussion to be had for individual pathology. And that's where I think the dual training, or at least if you're not dual trained, working with a partner closely, like our chairman, Dr. Zuccarello, was open trained, right? But he worked really closely with interventional neurologists and a junior partner who was dual trained to have those discussions. Is this particular pathology better for an endovascular and open vascular solution. And it's not always through a catheter. And so I think all of our research and a lot of these, really people who are pushing boundaries in labs and with technology are trying to make it where we hurt less people in the long run, and we make it where we don't have to do some of these more gruesome surgeries that often. I mean, I think that's the ultimate goal, is to make it where you don't have to use the knife anymore, or at least get as close to that limit as we can for our patients. So it's really an exciting field in that, as Dr. Boop said, forget, book chapters, which are 2 years old by the time they're published. Some of the journal articles you get it accepted in March. By the time it's actually in print in September, you could have 3 other papers out that have even expanded on what you were doing, and more trials coming out. So it's really advancing quickly, and some really exciting stuff in DBS and kind of machine interfaces and stimulation. I think if those open up, that could be a dramatic patient population with depression and some of these anxiety disorders and obesity that people are trying to find ways to treat with electrodes.